Dr. Robert Groysman, and I am a long COVID specialist. What I wanted to go over today was this recent article about a death from vitamin D, and that involved David Michener. And it raised quite a few questions and comments because the takeaway from the articles was that you have to be very careful with vitamin, but that may not have been the main cause of death for Mr. Michener. If we look at, let me share the screen here. If we look at his cause of death, we'll see that the postmortem findings were congestive cardiac failure, acute chronic kidney failure, hypercalcemia. That means there was more calcium in the blood than necessary, vitamin D toxicity, and ischemic heart disease, and that he was taking supplements of unknown amount, because we don't know, for the preceding 9 months. And by the time he went to the hospital, it was already too late. There was enough damage done that by the time he got into the hospital, he only lasted an additional 10 days. So the question I have is, why was he taking the vitamin D supplements in the first place? Was his blood tested and he found out that he was low, or he read something somewhere that made him take vitamin D? So vitamin D is a fat soluble vitamin, but is it a vitamin? So let me share a different screen, and I'm ready for questions anytime, by the way, and hopefully you guys can hear me, because I haven't heard anything yet. And just as a reminder that I can neither diagnose nor recommend treatments. This is a public forum. Answer generalized questions regarding long COVID, POTS, chronic fatigue syndrome, and MCAS. So let's take a look. Perfect, great. So let me find my document here. Perfect. Okay, so what is a vitamin first? And it's important to define it because it is an organic compound, or a group of organic compounds, that is essential for normal growth and nutrition, and is required in small amounts from the diet, typically, because it cannot be synthesized by the body. Well, look at vitamin D. It is not essential because it's not even considered a vitamin. We can make it from our skin, from sunlight. Therefore, it doesn't really truly meet the definition of vitamin. Even though we still call it vitamin D, it may not be truly a vitamin. Just something to keep in mind. Even though it's not essential for it to be in foods and supplements, it is necessary for health. Not just bones, okay? It makes strong bones and strong teeth. If you have a severe deficiency, especially early in childhood, you can develop a condition called rickets, which is very brittle bones and remodeled bones and failure to vitamin D comes in two natural forms. It comes as vitamin D2. We hear this all the time. Ergocalciferol, and that comes from plants, mushrooms that have been exposed to sunlight. That's very important, and yeasts. Vitamin D3, cholecalciferol, comes from fatty fish egg yolks, and the fish would be like tuna or salmon. And it's the same stuff that we form in our skin after UVB exposure. So this is important. There's three types of UV rays. There's UVA, UVB, and UVC. And UVB is what's needed and important in order for the skin to produce the vitamin D3. It's important to note that D3 is 3 times as potent as D2. So here's the general process. When we first start, okay, whether it's in the skin or an animal or if it's coming from a plant, they are not biologically active. That means that if you consume these and you lack the ability to activate vitamin D, it's not going to work. So what circulates in your blood may not necessarily be active. So the levels may look normal, but they're actually not active or working. So what happens? There's 2 steps that need to happen. The first step happens in the liver. Okay, and that's after obviously vitamin D is absorbed. There's an enzyme in the liver that adds a hydroxylase, a hydroxyl group at the 25th position, and it becomes calcidiol. And then it circulates around and goes to the kidneys, where another hydroxyl group is added. This one in the 1 position. This is calcitriol. And this stuff is about 100 times more potent than the other 2 that were, I guess, half activated just from the liver. So you can see that if you have liver disease, if you have kidney disease, these can both impact vitamin D activation and likely vitamin D elimination or metabolism. So vitamin D in general is fat soluble, as I said, and it needs to be taken with food or with something fatty, some kind of oil or some kind of fat, in order for it to absorb better. What are some levels? Well, depending on which system you look at, the UK or the US, most people are going to be in this zone, 50 nanomoles per liter or 20 nanograms per ml. Levels below 30 are considered low, and levels above 125 are considered too high. So this gentleman, he was very elevated, if I remember correctly. Let's go back to that one. Here we go. And I'll get to your questions here in a moment. Let me just finish this thought. He tested to 380. So that's more than 2 times the highest limit that we want to see. And it's really unclear what exactly happened, how much he was taking. I will get into hypercalcemia, which is high calcium in the blood, and what that usually looks like. And I'll also review hyp's not enough calcium in the blood and kind of what happens with that. All right, well, let me turn this off here, and we'll start looking at some of the questions. So the first question comes from, hang on, Chris Wallace. And let me see if I can get that on the screen for you guys. Here we go. Do the outcomes of CFS depend on the activity level of the patient? In other words, does someone who have more crashes more likely to progress to severe myocephalic encephalopathy, chronic fatigue syndrome? I don't believe so, but the setbacks that I see after crashes is it takes so long to get you back to even baseline. So crashes don't cause chronic fatigue syndrome. Chronic fatigue syndrome causes crashes, or more specifically, post-exertional malaise. That's one of the cardinal symptoms aside from the severe fatigue that's associated with chronic fatigue syndrome. So it's not, I mean, it's not beneficial for you to go through crashes. That means you haven't learned either how to pace yourself or um, what you can do before you do get into a crash. I hope that answers your question, Chris. Let's see here. Next question is from a Facebook user. And the question is what is helping people with the neck and back pain that's going into our face? So, what I have seen in my own practice and in general is what's called the close hanger effect or the close hanger pain. So, if the hook part was part of the face, then the arms of the hanger would overshadow or overhang your shoulders and into your chest. So basically, those are the main areas that tend to develop pain from long COVID, or we see that in long COVID. I believe a lot of this tends to be neuropathic pain. Some of the facial pain can come from trigeminal neuralgia or irritation of one of the cranial nerves of the face. I believe this also is in the same constellation of tinnitus, sinus pressure headaches, things like that. Um, what is helping is to treat the neuropathy. I mean, that's really it. There's nothing magic or special about this. Is to treat the neuropathy, and there's multiple different ways to do that. Next question is also from a Facebook user. What are your thoughts on nasal sprays such as Covixil or Nasomin before possible exposure to viruses? There's been actually several nasal sprays that have been shown to, I guess, stop viral transmission, or I don't know exactly if it's 100% successful, but some of the sprays are successful at reducing you catching or getting infected with COVID. Best thing to do is obviously avoid crowds and people who are sick. That's easier said than done, especially when you work, especially when you have to fly, especially when you have to take the train or bus. So yes, I do think some of the sprays are helpful. I need to look up those two specifically because I need to see the ingredients in them, because I made a list channel of all the common sprays, and I don't remember what that one in particular has. But there's several different ingredients that have been successful at lowering the risk of catching COVID. Lowering, not stopping, not eliminating, lowering. Very important. All right. I hope that answers your question. Let me see here. What is the relationship between vitamin K and D? I've seen comments that those should be taken together, but didn't understand why. Well, the only similarity that they have is both of these vitamins are fat soluble. Okay, so there's actually 4 fat soluble vitamins, and everything else is water soluble. So what does this mean? When you take a fat soluble vitamin, it absorbs better if it's in a fatty meal or in oil or in something like that. That's number one. And number two, it has a potential of being stored in your fat. So that's really the relationship there. They do very different things. I'll go over what vitamin D does at some later time. And vitamin K mainly helps in producing four different factors in the liver that help with coagulation. It's part of the coagulation cascade or the clotting cascade. So they don't really interact with each other outside of with absorption. I'm sure one would improve absorption of the other. Other than that, I don't think there's any correlation or relationship between the two. A Facebook user is asking about what do I think about brain damage done by COVID. So, I mean, it's kind of hard to really ignore that COVID can at least get into the brain through the astrocytes or kind of doing a Trojan horse type entry into the brain. We do know that it can damage dopamine producing neurons. Okay, that's been documented. I'm not all too impressed with the white spots or the gliosis that's found on brain MRIs, especially the specialized ones. However, because these sometimes appear in migraines, we see these white spots appear and then they disappear. It's not necessarily indicative of disease. Okay, there is a reduction in brain volume compared to people who have not been infected by COVID. The clinical significance of this is still uncertain. So when I think of brain damage, I think of like a stroke where blood supply was cut off and a piece of the brain dies. Something like this does not occur during COVID or long COVID unless you actually get a stroke. So I guess to answer your question is while I am watching it, I don't really consider it brain damage per se. We're talking about microscopic level decrease in certain neurons. And there is a decrease in volume, but again, we don't know what the clinical impacts of that are. So I'm going to go bring her on. I think she may still be on the phone. There she is. Hi, Amira.
Hi, can you hear me okay?
Yes, I'm going to be taking off this question about brain damage here, and we're going to move on to the next question, and then we'll introduce you. Okay.
Okay.
Next question, also from a Facebook user. Is a consistent low HRV, which stands for heart rate variability, and it's different from heart rate. Okay, it's the changes between beats of a heartbeat is what we're looking at. Is it a good indicator of long COVID dysautonomia? And if yes, what can help improve HRV? So first thing you need to understand is that the autonomic nervous system is segmental. So what does that mean? That means that one part of it could function normally and another part of it can be abnormal. And even something like POTS, we occasionally see different symptoms because it's involving different areas of the autonomic nervous system. HRV is a good indicator of general health. It's also an indicator of parasympathetic tone. The goal really shouldn't be to HRV. The goal is to do things that will heal you and make you better, and that in turn will increase HRV. So if you're chasing HRV, you're really not going to be able to catch it. It's just a reflection of at least one part of the autonomic nervous system. In this case, it has to do with the chest, and it includes the stellate ganglion as well. In how well your body is responding to these changes, to heart rate and to blood pressure. to breathing and to standing. So that's all part of it. It's not the only measurement of autonomic nervous system function. There's many others, um, but they all have to focus on one of three things. And this is going to be an effect of breathing, such as holding your breath or breathing deep, heart rate, and blood pressure. And the last one would be sweat production. That looks at sudomotor and other part of the autonomic nervous system. So my advice is not to chase HRV, but to work on getting better, and the HRV will improve as a side effect. So we have joining with us Amira from Long COVID Association, and as you know, she runs a nonprofit organization helping people suffering from long COVID, chronic fatigue syndrome, POTS. Correct, Amira?
Yes, thank you, Dr. Groysman, for having me here today and for doing all of these live streams with us since last year. It's been a real mission, to help educate the community, because I see a lot of the same questions being asked over and over again. It's like the information is not getting to people from their healthcare workers. So I'm hoping our advocacy and doing these regularly will help educate not only other scientists, your medical peers, but the community, to ask the right questions of their doctors, to look at the comprehensive nature of what long COVID is. Like you just mentioned, trying to attempt to solve one thing for dysautonomia without looking at the gut brain immune axis, or any of the other gut axis, is like trying to put sandbags along a levee, and you've got a tidal wave coming. You have to address everything in the right order and pay attention to the foundational problems that are happening. You have to look at it from a molecular perspective, you have to look at it from a systemic perspective, and you need to look at the patient from, that real clinical history, and a lot of that is getting missed in these really short appointments where patients have waited a long time to see the doctor and they're nervous and they don't get to ask the right questions. The doctor, hears one thing and then goes to do their differential diagnosis without hearing the whole situation. So I'm hoping today we can touch upon some of that, and how, you are unique in that you take the time ahead of time to understand the patient and ask the right questions and create a strategy, patient-centric approach, precision medicine wherever available. You really work with the patient to fix the underlying problems, to get at, a way to recover their life, until there is a molecular cure, until there is a way to completely clear out
I think we're
the
coming pretty
instructions
close.
for this
I really think we're
virus.
coming pretty close
Yeah,
um,
yeah.
to a complete treatment. Address this question really quick because
Okay.
I wanted to mention that the new therapies are experimental, okay? And it says on the page, I'm not recommending that you try these. These are just some ideas that I've come up with. And, I'm a little concerned, obviously, if you're thinking to try these on your own. A lot of them don't have any studies yet looking at how they work, or if they work, or if there's side effects. So most of the things that I actually recommend are based on studies or um, study-based evidence. These were kind of my thoughts and new therapies in terms of like what I think we should look at, or there could be some improvement from some of these, but I have no idea. I've never tried them. And to try things on that page without discussing it with your physician first, okay?
Right. Medical
Um,
monitoring is so important because as you improve some of your health, the amounts of some of these medications and supplements are going to change. Your requirements are going to change, and you need a doctor who's committed to working with you to regularly check, how you're doing overall, and that's the thing. Like, have you mentioned already about that recent
yeah,
article
yeah, no, that
about 89-year-old businessman from
yeah. I started with that, and we went through kind of what I think was going on. And number one, they didn't mention how much vitamin D he was taking, um, and what he was taking it for. So those two are very important. And vitamin D is relatively benign, but can accumulate in fat because it is a fat soluble vitamin. And you have to know what for having hypercalcemia, which we didn't get into yet, but I wanted to go over
okay.
at some point. Basically, magnesium, calcium, vitamin D, and phosphates, because all of those are mixed together and they affect each other. And if you take too much of one, it can actually cause a severe decrease.
I
So kind of
think
an
one
interesting
thing,
mixture.
it'll be interesting if we can like share that report and you can explain to us when
Sure, and I have
after
it.
you do your presentation.
Sure, and
um
I have it right
oh,
here. So
wonderful.
whenever you're ready, we
Excellent.
can we can
Yes.
we can review
Yeah,
it.
because I
Okay.
found some of the things very similar to people with chronic kidney disease, and a lot of folks are facing some issues with their kidneys after COVID. And you know, your the connection between the heart issues and the kidneys, it kind of reminded me of like hyperparathyroidism and having to watch for the too much calcium in their diet. And all this better than I do, because I'm just a novice when it
Yeah.
comes
Well,
to.
I worked on it. I worked on it for the last day to kind of put something together. But a lot of times, like I said, we don't have a chance to really talk about a specific topic. So I'll probably put that in the video. But I will try. I
Oh,
will
that'd be
try to
great.
get to. I will try to get to a couple of more things because it is very interesting and it's important to know um,
Yeah,
that a lot of these minerals are responsible for nerve transmission.
right. And also
Okay.
immune support.
Yeah, I'll get to that part too. But
Okay.
so let me see. I just jumped to that question because I wanted to make sure that people knew that that particular page wasn't recommendations, but really kind of me thinking out loud. Um,
Right. And everybody's, there's this saying, this uh, one doctor said, who was, in, he said, if you've seen one case of long COVID, you've seen one case. Everybody is pretty much unique, in their constellation of symptoms and presentation. And some may have different symptoms show up at different times. And you see that more than anyone. That's why you take the time to get a
yeah,
really
no two
good.
cases of long COVID are alike. It's
Yeah. Even between my son and I.
it's really a funny disease, and
Yeah. And
yeah.
with the ability of SARS-CoV-2 to infect over 61 different tissue types, blood vessels, immune cells, blood cells, no wonder we have over 200 different symptoms appear, and more than you taught us, more than over 100 of them are neurological related. So it makes it
Yes.
really like a sleuthing event to figure out what's going on. So
Right.
um, anyway, I'm excited to hear what you have to say. Been looking forward to this
Well,
all week.
I will. So let's talk about this Facebook user asking about long COVID caused nerve entrapment, and my doctor recommends surgery. Do you think I can get better on its own, or if I wait for LC to heal? So I have no idea how to answer this question because I don't really understand how long COVID is causing nerve entrapment and which nerve we're talking about. I don't know if you're
Right.
talking
Yeah.
about vagus nerve, the sciatic nerve. I mean, there's many nerves in the body, and not all of them require surgery to correct. And I'm also curious how you became entrapped from long COVID. So I have, when I have these kind of questions, I usually have way more questions than answers. I guess
Yes.
because, yeah, I mean, like to me, it's a puzzle. And
Right.
in order to be able to get to the bottom of it, I need a ton more information.
Yeah. I do have one example,
So that's the
personal
better question.
example. I ended up, I was an athlete for many years, from age 10 till 28 in track and field heptathlon. And I managed to get by with, minimally invasive treatments for carpal tunnel that would come and go. And sure enough, during the pandemic, my hands worsened and accelerated and seemed like they aged to age 80 in a very short period of time. And I ended up having to have bilateral carpal tunnel release because there was just so much swelling. And I think it had to do with autoimmunity. Now, I asked the doctor after, I said, "Did you biopsy my tissue?" Wondering. No, we didn't do that. I was like curious, but it took a while, along with a lot of different supplements that I knew would support my nerves and my health recovery. But it required integrative, like integrative medicine. I had injections at first. I had injections during surgery. I had the injections in my hands. I had to use all kind of different therapies to get my hands back and to get all the feeling back. And the nerve damage was confirmed by the, what was it, nerve conduction EMG studies that you talked about. So I also at that time had higher than levels of positive ANA tests, which have since been negative for the past 2 years. So using a lot of these different you know high, experimental therapies that we want to investigate further, evidence, put them in evidence-based studies. I improved, in my hands, and a lot of things improved. But I could tell that there was some autoimmunity happening in my system. It was like I was becoming my mother in her late ages of her life very quickly, and I couldn't understand what was happening to me. And I don't know where, like you said, you need to know where the entrapment is happening, where the swelling, where the situation is, because a lot of people with Ehlers-Danlos have connective tissue, and you mentioned Ehlers-Danlos like MCAS. All these things are connected, so you need a lot more data
Yes.
to answer that question.
Right. So let me just answer the question this
Sure.
way. Um, and I saw he post here two other comments. When I look at entrapment, I look at two things: function and progressive. So, are they becoming progressively worse? Okay. If they are, then surgery becomes more likely, especially if it involves motor. In other words, there's weakness. You're not able to stand, you're not able to walk,
Yeah.
things like that, over numbness or tingling.
Yeah.
So weakness and a lot faster. Okay. So I basically use those two parameters to decide if I should refer a patient to a surgeon or not. Um, I don't get too excited about numbness or tingling unless it's progressive.
Right.
If there's weakness or weakness is progressive, then this in general kind of leads me to a surgical consult at least to
Like
get
when
their
you can't
opinion.
hold a knife to cook, or hold the mouse very well anymore, or grip things. Um, and then you do the
Things that
nerve
are explained
conduction at your
by one
clinic,
or
right?
two. I do the conduction in my clinic, but a lot of times I don't even need to. I know which nerve is involved. If it's
Okay.
the entire hand, it's not going to be one nerve. If it's the entire foot, it's not going to be one nerve because both of those have 3 to 4 nerves going into controlling the motion and sensation. So because it's not just one nerve, if somebody tells the whole hand is numb, and I'll ask additional questions, I'll say, is it both sides? Is it the volar side and the palm side both? Do you feel it in your fingertips? I mean, I'll ask additional questions, and then we'll run through some neurologic exams on the hands. So I can figure out what nerve it is just from from those without an EMG, but sometimes it's not involved. It's going to be the median nerve, which is responsible for carpal tunnel. And because it goes underneath a very rigid ligament, it can be compressed.
And
So that's
when the
that's really the
fingers
best way
lock
I
up,
can.
like sometimes fingers
Again,
would lock up and get stuck. It was very
right,
weird.
right. I
Things
mean,
that I'd never experienced.
there's a few different,
Yeah.
there's a few
We
different reasons for
need you on the
that.
East Coast. We need you. Satellite offices across the United States.
Well, there's only 5 days a week or 7 if you consider, the
Yeah.
entire week, and that's not going to be feasible, obviously, in each office.
Oh goodness. Okay.
Um, our next question comes from a Facebook user um, asking if we are considered immunocompromised if we have long COVID. So, and this person also takes rapamycin once a week, which may be due to long COVID, like for mitochondrial health, or it may be for organ transplant rejection. I don't know. Um, I consider the immune system dysregulated. So, people who get autoimmune conditions are not immunocompromised per se, they have an overactive immune system. And then we have people who tend to get more infections more readily. So I think it's a combination of both, but I think the easiest way to look at it is just dysregulated. It's not functioning like it should be functioning. So some people get an up regulation of the immune system, and they start forming autoantibodies and allergies and reactions to foods that they never had to before, or to allergens that they never had to before. And then we have the other subgroup that seems to get infected, 9 times every week with everything. So I don't think it's uniform. I just think it's dysregulated, and it's also possible that it goes from one to the other in the same person due to this dysregulation.
The microbiome gets shifted one way or another, because
Well, that's part of it. I mean, the microbiome does have input and influence on our immune system, but I was just speaking as a whole.
yeah.
As a whole, not considering any specific part of it. Rapamycin, though, does immunocompromise in a way because that's what it's meant to do. I mean, it's a medication that supposed to help downregulate the immune system or modulate it to an extent. Um,
So that you don't,
so
it
let
should
me.
probably be helping for the autoimmunity part, so you aren't attacking yourself as much, right? In a way?
Well, yes. I mean, that the point of using it in organ transplants is to reduce the rejection factor,
Okay.
since even if you match things perfectly, it's not completely matched. There's going to be some antigens on the organ that are going to eventually set off your immune system to say, hey, this doesn't look like me.
Yeah, not
And
perfect.
it just helps. Yeah, so that helps that quiet that down a bit.
Okay.
Um, this is an interesting question.
Okay.
Let
Which
me
one?
just find it here. Well, I'm getting to it. Hold on.
Okay.
um, I'm trying to find it in the list here. And every time you hover over it, it turns into show and hide. So it's hard to read.
Okay.
I'm trying to find that question, which I see there, but I don't see on mine. And I'll go back to the other ones here in a moment, but I think it's just kind of an interesting question. Hi, would you consider subcutaneous heparin for fibrin coagulation problem? And I'm going to say no. And here's why. First off, there are plenty of better choices than heparin if we're talking about a coagulopathy. That is, you've demonstrated coagulation problems where you're forming clots, okay, such as DVT or pulmonary embolus, or similar, or you have atrial fibrillation. Um, this is not for microclots, okay? I still consider microclots hypothetical. I know there's been a lot of papers on it. I know Dr. Vaughn loves microclots and he tests for it. In my opinion, in my professional opinion, based on everything I know so far, um, I have not seen microclots as a pathology yet. Okay. You haven't demonstrated to me that it reduces blood flow. You haven't demonstrated that it causes larger clots. Large clots are a part of long COVID, at least early on. Large clots are part of COVID. There have been instant deaths from coronary and thromboses in the brain, cerebrovascular thromboses. These people drop dead. Okay, this is not I'm walking around with my microclots and I'm feeling sluggish. Okay, that's not what we're talking about. Real clots are pulling out of these cadavers. Okay, these are massive, huge clots. Anybody who got these or gets these, they're dead. There's really no way about it. They're either going to lose a limb or be dead. They're just not survivable. The mortality would be 100% there. These are not microclots, okay? Microclots are microscopic clots or formations or groups. I don't know how you want to put it together, but they have not, in my opinion, demonstrated to show a decrease of blood flow or stopping blood flow anywhere. If you're using microclots, my hand turns white. Well, Raynaud's disease or syndrome can your hand white from vasospasm. When your arterial supply basically spasms in your hand turns white. The same thing can happen in your foot. That has nothing to do with clots. That has to do with a spasm of blood vessel stop flow temporarily. Okay, so I want to make sure that you're not considering using heparin for microclots. But if you truly have a clotting disorder where you're basically clotting more than not clotting, um, there's plenty of medications that would work just fine and are less intrusive than heparin. Heparin is often used for short terms. For instance, when we're trying to do surgery on somebody who's on blood thinners and we need them to stop 5 days before, but we also know that heparin has a very short lifespan, so we'll transition them to low molecular weight heparin at home with a nurse, and they'll get off their medicine for 5 or 7 days, and we can stop the heparin 12 hours before the surgery, and boom, there you go. You could do the surgery and then away. So let me go back because I know I skipped a bunch of questions.
Okay.
So I thought I just saw it and it looked interesting, so I wanted to mention it. And
What are your thoughts
remember,
on?
science.
I'm sorry, didn't mean to interrupt. I was just curious.
Let me just finish. You're a little behind me, so you're probably not catching everything. But I just want to mention that science and medicine is not a popularity contest. Okay, it's not how many people believe in whatever you're saying or how many articles that particular approach gets. Okay, it's about truth. It's always about truth. It's always about getting to the truth. And so and this is kind of where I'm going with this microclot thing. I saw a lot of papers on it. I mean, news articles, papers, doctors talking about it on shows, on YouTube, on TikTok. That just because it's popular theory does not make it true. Okay, just something to keep in mind. And same thing goes for what I think as well. I'm usually the contrarian, but stuff that I say may turn out not to be true. 10 years from now, 5 years from now, based on new evidence. And if that's the case, I will change my opinion. And that's really how science works. So I'm sorry, what were you saying, Amira? Why don't you talk while I look
I
for this?
I was wondering about your thoughts on like some some papers I'd seen had there was some consensus among some scientists. Not all of them are MDs. Some are MDs, some PhDs, about the use of like a baby aspirin, the 81 milligram, at least at part of the times. But then sometimes some cardiologists are like not to use aspirin at all. And then also fish oil helping to help with some of that, and the vitamin D also was actually recommended for improving the overall quality of the blood labs. I just you know I know one thing doesn't work for just one person, but there were a lot of folks saying some of these things in the right combinations can help support your body do what it needs to do to, you know, improve, and spike, that those large clots are hard to clear out of the body, and beginning ones I would suspect would be, something that is more manageable to work on. But is it happening everywhere? I mean, is it part of, like you taught us?
Your end or your end?
Oh, okay. Can you hear me now? Okay.
I can hear you, but your
Can you
video
hear me?
freezes and then it gets choppy, like
Oh,
every other word.
okay. Gotcha. All right. Well, it's okay. I was just wondering about, possibly the use of the baby aspirins, what your thoughts were on that.
Sorry,
And
I'm not sure what you're trying to say. I want to know, guys, are you hearing me clearly? I on my end, or if it's on Amira's end that it's choppy. So I'm not sure if it's just me hearing her choppy or you guys hearing me as choppy.
okay.
Okay, so is it me? Am I the choppy one?
I think you
Okay,
might have
so
to
I'm the
come out
choppy
and
one.
come back. But I can hear you, just you're not as clear as I can see myself. So I can hear you
Well, it's
clearly every
Sunday.
now and
My kids
then.
are home and they're probably on the internet. All right. Well, I'll do the best I can then. I know we have a lot. We know we have a lot of
Okay.
questions coming in. So let me
Uh,
start getting to some of them. If long COVID manifests like dysautonomia and MCAS together, on which one is useful to focus first? So what I tend to do is um, symptom analysis. Okay, with, and I split things up into four categories or four causes. The four causes are the dysautonomia, the MCAS, the gut dysbiosis, and the mitochondrial dysfunction. And once I've done that, I see which cause or category has more symptoms associated with it. Then we talk and supplements and other medications that people take. And that's kind of how I hone in into the therapy. So each person's therapy is going to be different. It's a unique therapy for each person who's long COVID because it manifests. So, if you get 10 patients of mine together, they're all going to be on different things and they're all going to have different recommendations. Some of them may look similar on the surface, but when you dive and look at the causes, then kind of the truth comes out. So by focusing on that, I can select the right things to do and the right recommendations to do. So it really is. I mean, you could probably get 100 people together and they'll have different treatment suggestions or recommendations. So it is. If I think MCAS or histamine issues are more responsible, um, I would tackle that first. I may test first. I may obtain a urine or blood sample to confirm my suspicions. If I think that the dysautonomia is causing the issue, I will tackle that first. So I can't really tell you if you have two together. Some people have all four. I have had a lot of people with all four things happening, just to different degrees. So I focus on the ones that I think are the majority, the big players, and basically the driver and the shotgun, and then we do the backseat drivers. So they may all be in the car, but they contribute differently to to the disease or condition. Okay, so it's a difficult question to answer without knowing specifics. And like I said, you can gather 100 people that I've treated, and they will have completely different therapies and suggestions in different order, and different parameters.
And even in the dysautonomia, you've got so many variations just within that, from what I've been.
Yes, even dysautonomia, I will treat differently depending on which segment is. So, if I treat POTS and different forms of POTS differently than I would somebody who has dysautonomia, for instance, with loss of brain fog or fatigue. So, issues with their legs, or abdominal issues. So these are treated differently, different choices, and um, different dosing. So it really is a very customized treatment plan. What I do, okay, and not everybody gets recommended to have the SGB or the stellate ganglion block. Okay, in fact, a lot of my patients don't, because I don't think dysautonomia is a issues or more gut dysbiosis. Okay. Um, okay, next question. What's my opinion on taking a short course of oral steroids with long COVID to treat rheumatism flare? So, a rheumatoid uh, see symptoms of fatigue and exercise intolerance. So, typically with short dose oral you have what's called a ramping dose and then a deramping. The point of doing that is to reduce the fat glands, because just take a high dose of oral steroid, even if it's for a short term, your adrenals kind of quit producing cortisol. And cortisol is a very necessary hormone for dealing with stress, not the kind of stress you, okay, or your boss is making you mad. I'm talking about biological stress, okay? So I've mentioned this a few times, but probably the most stressful thing that your body can do is go from a sleep state to an awake state. Your body knows this and knows your circadian rhythm, hopefully, and will say, okay, she's now, I'm going to start producing cortisol. Now, of course, if you wake up an hour before you were supposed to, your body's confused. It doesn't know what to do, and you don't have the release of cortisol, and you feel like crap. If you've ever been woken up from a sound sleep and you don't go right back to sleep, you know what I'm talking about. So that's one of the most stressful things your body can do on a regular daily basis. Infections are a stressful thing for your body because of oxidative stress. Okay. Anytime your sympathetic nervous system is activated because of fight or flight, that is a stress, and your body will produce cortisol, or should produce cortisol, to help your body deal with that stress. Okay. So short course of oral steroids are fine as long as it's done in the right sequence. And it shouldn't technically make long COVID worse. I mean, steroids are sometimes used during long COVID. They may make the symptoms go away temporarily as well. And but they usually come right back as soon as you stop. And that has to do with the steroids, or corticosteroids to be specific, not mineral corticoids, but corticosteroids. They modulate or reduce or inhibit the immune system. Okay, so that kind of goes against the whole immunocompromised situation that was mentioned earlier, because if you were immunocompromised, taking a steroid wouldn't really help. But it helps when your immune system is overactive, such as it is in rheumatological conditions, because you're forming autoantibodies. You're forming antibodies against yourself or against a component of yourself. And that has to do with both an abnormally functioning nervous system and also an overactive nervous system. Now, nervous system. I meant immune system. So that goes against immunocompromised as well, since steroids temporarily help with long COVID symptoms. But I think that the immune overreaction or overfunction is a symptom as well. It's not a cause. So I think it's a consequence of everything else that's going on from the causes I mentioned. All right, I hope that helps.
Here's an easy one.
So we have a comment.
Yeah. Are you treating
Okay, go
individuals
ahead.
out of state via telehealth? That's an easy one. Yes,
Yes, I am.
globally, right? Yeah. Go
Yes,
to
globally.
covidinstitute.org and there's a
Because
contact.
there's unfortunately that understand long COVID and POTS and dysautonomia and chronic fatigue syndrome. Take it
And
seriously.
MCAS.
Don't gaslight and do
Yes.
something beyond just testing.
And also, Dr. Groysman set up his website to be translated. You can select different languages. You know, we've had followers from different countries who speak primarily French or other languages. Now, I mean, you can go and select the language and get the same information translated into your native language. And then also, appointments can be done with a translator for over, what was it, over 200 languages, Dr. G? Dr.
240.
Grossman? 240 languages. So that's commitment.
240.
Yeah. So,
Live, and human translator.
yeah. So, and another key
Kind of
thing
like UN
is
style.
I believe you can prescribe in the US and Canada, right? And then
Not
help
Canada. I mean,
put, okay, you can
I can't
prescribe in
prescribe
the
in
US.
Canada.
Okay, so you can prescribe in the United States and then only what?
I can only prescribe in the United States, not in Canada or internationally. But I can tell you
Okay,
what to get.
right. You can help create a treatment plan and work with doctors overseas to help you get, on the road to recovery.
Yes. Yeah. If you have a
So,
doctor, if you know of a doctor, if you have a doctor that doesn't gaslight you about long COVID and the related conditions, and is willing to work with somebody from the United States, I'd be more than happy to do a collaboration. Maybe one in each country, maybe two would be nice. Um, but yeah, I mean, that would certainly be more helpful. But the message I'm getting a lot of times from overseas is, I can't find anybody that will treat me or they'll talk to me even. They say it's in my head. They say it's a psychiatric thing.
part of the problem in the UK is like 30% of the medical workforce has long COVID themselves. Very high
Right, and
number.
I've had COVID and I've had long COVID, and I've had vaccine issues as well. I've been vaccinated 4 times with Moderna. So I mean, I know what you guys are going through. It may not have been as severe, but let me tell you that fatigue that hits you, um, it's like a brick wall, and you can't do anything. or the shortness of breath. Being not able to walk 3 or 4 steps to the exam room. Um,
Yeah.
so had it. I've had seen it. Um, I know it's real. Um, why don't we go to the next question here? What is your experience as to typical number of SGB treatments for dysautonomia required by different clients you've treated? What are the variables that cause clients to need multiple SGBs? Are there known increased risk dangers of having multiple? So again, it's a very loaded question. It's very individual. Not everybody has to get a right and a left side. Okay. In fact, contrary to what some believe, I will discourage people from getting both sides if I feel that the one side was successful and they feel that it's successful. I don't just do it for this. Okay. Here's how many numbers are required. Everybody's going to be different. I've had patients that I have not seen back after 3 years, probably more now, in 3.5 years, after one set. Some require 2 or 3 to get to a point where they didn't need anymore. What parameters, I guess, cause the need for multiple? Well, if you live in a stressful environment, stress has been shown to increase your sympathetic tone, and therefore you're more likely to revert back to the symptoms again, getting sick again. If you have a respiratory illness, especially COVID, but it could be the flu, that can set it off. Why? Because illness increases your oxidative stress and therefore increases sympathetic nervous system output. Surgery sometimes can do it. Okay, certain surgeries, I don't know if it's the anesthesia or the surgery itself. Surgical stress is real. That's why we have anesthesiologists. What anesthesiologists do is they compensate for the surgical stress by increasing the anesthetic. But surgical stress also increases sympathetic output. It causes your heart rate to go up. It causes your blood pressure to go up. It causes your respirations to increase. So any of those can basically set you back or get you back to having your old symptoms or having some of your old symptoms. That's really the best way I can explain, who needs it, who doesn't need it, how many you need. It's really individual. There's really no increased risks or dangers of having multiple blocks, assuming the person who's doing it knows what they're doing. And if I see somebody and they've had at least 2 sets with me, okay, I've done one set and then the second set, I may offer something that would prolong the block, such as using botulinum toxin or using radiofrequency procedure, which is also all done through needles. There's no cuts or anything. But there's ways to make it last longer so that your body has enough time to adjust. So for instance, if you revert back after a few days or after a week, and I do it again and again, you revert back short term, okay? So the goal there is to leave you in a block state longer so that your body has more time to adjust. So we have a lot of more questions that are popping up. I don't know if I'm going to be able to get to everybody. I hope I will. Let's see here. I have a question here. I'm not sure. Something with pulmonary function, I take it. Maybe if you can clarify what PFO is for me. Thank you. And try not to use abbreviations if you can. Do I think long COVID is caused by damage to the ANS or viral persistence or both? I'm not a big supporter of viral persistence. As I mentioned earlier, I believe the cause is mainly by the four I mentioned, which is dysautonomia, the mitochondrial dysfunction, the gut dysbiosis, and MCAS or histamine. Um, there may be a persistence of viral proteins, but it's not an infection per se, and it's not prions. Um, there may be production spike protein or a different protein that's causing or not causing, but maybe prolonging the effects of what's going on. It's kind of a constant stimulant or irritant. Okay. What do I think might be the mechanism behind the lack of blood flow from minor cuts? For instance, when I shave my legs in the shower or nick myself, I typically bleed. Blood flows. Now, when it happens, there's hardly any blood. So it really depends on the depth of the cut. So, I mean, typically when the cut is very shallow, it's just going to be capillaries that are nicked. And I mean, I'm not really sure what you mean, that you don't bleed. You may not have cut it deep enough. I don't know. You may have thickened epidermis. Um, I know some guitar players, they have like really large calluses on their hands, and they even sell a device used to prick fingers for testing diabetes, for instance. That if you prick it, somebody who has a lot of calluses, as an example, it's not going to a regular size one is not going to go deep enough to draw blood. So my question to you is these cuts that you're getting, are you sure they're cuts and not just slicing into the epidermis, where it's not deep enough basically to slice through capillaries to cause blood flow? Um, so that would be my question to you. Amira looks like she fell off. Hopefully she'll be back on shortly. Uh, so this is a long one. Um, talking about generalized joint hypermobility. And yes, I do think that joint hypermobility is related to COVID, but I think or actually to long COVID, but I think that it's more related to the MCAS and piece of elastic, some of the proteases that are inside mast cells, that can dissolve or remove some of the components of connective tissue, leading to the hypermobility. But it's not just hypermobility; it's also stretching too far and not being able to spring back. Um, so if I see hypermobility, I focus more on MCAS or mast cell related conditions, not just histamine, but basically stabilizing mast cells. And that's basically the general, I guess, the general course. I mobility involved, and it's not something genetic like Ehlers-Danlos, that you've had since you were 5. Um, sure, we can talk about Epstein-Barr virus reactivation, Shireen. I've actually talked about it a few times, and I have a video on it on my YouTube channel as well, talking about Epstein-Barr reactivation, how to test for it, the significance, and everything like that. Okay, if you're interested, just COVID Institute on YouTube and look up um, the video. Okay, and if we want to talk about it more, that's fine. Um, so let's see what else we got here. So when I look at vax-induced versus COVID-induced, I treat a lot of them very similarly. I would more likely use, for instance, IVIG in somebody who is vax injured or vax induced neuropathy or small fiber neuropathy. Oh, I think Amira's back. Okay, good. There she is. I can't hear you.
We have like some impending like rainstorms, and apparently in this
Okay.
building. I
Okay, no
apologize for
worries.
that.
No worries. I covered for you.
Thank you.
What do I think about baby aspirin? I mean, do I think it's okay? I mean, the latest recommendations um, for even cardiovascular health, I believe have not included the baby aspirin. I believe the latest ones, and obviously this is outside my area of expertise, but aspirin can, for instance, cause a problem with mast cells. In some people, it's okay, but in other people, because it works on too, it can cause an issue and basically cause a flare for your mast cells. Okay, it's a great anti-inflammatory. It can cause gastritis. It can cause gastric ulcers. But baby aspirin, all in all, I mean, it's pretty safe. It's available over the counter. And, just because it's available over the counter doesn't mean you can do whatever you want with it. But
Right.
it's what the CDC, or not the CDC, the FDA determined to be safe, obviously, the dosages that was released. So, um,
I've seen a lot of
uh,
good things, but even my own cardiologist was like, "You're too young to be taking aspirin," you know. So, and also some people who have a history of asthma are very sensitive to any kind of NSAID, like you said, MCAS. So you have to work with your
if
doctor
it
about
has
what
to
to.
do with and you missed this, Amira, but I talked about hypermobility and what I do, and I usually look at mast cells in somebody who does not have a genetic predisposition to Ehlers-Danlos or Marfan's or another kind of hypermobility type condition.
Right.
There's a whole spectrum of them.
Right.
Um, Hang on, I'm trying to. Okay. Next question is from a Facebook user. How does one re regulate one's immune system? Well, because I don't think that the immune system is a cause, I think it's a victim or a casualty of the state. Hang on, I gotta reposition myself because my back is starting to hurt now. Um,
I'm sitting on
so
pillows myself,
yes,
so
so LDN, low dose naltrexone, really only targets neurological inflammation. It doesn't really help with the immune system or anything else. And yes, proper diet, sleep hygiene, vagus nerve stimulation all help regulate your immune system. Absolutely. Anything that makes you feel better is going to also decrease your oxidative stress. It's going to decrease your physical stress and your mental stress, and that's going to help with your immune system because our immune system is really tied in to our level of stress, and sympathetic and the parasympathetic nervous system. And they do just exactly what you think they do. Sympathetic kicks it up into a whirl, and it's like a Tasmanian devil. And the parasympathetic quiets it down and relaxes it. Okay? So you need balance between those two, and everything you mentioned can help you achieve that.
And even
Uh,
like another one is part of the functional medicine side of this list, meditation and community, relationships between people, feeling connected, and laughter, all kind of things to support vagus nerve, singing, laughter, the vagus nerve stimulation, all, breathing, breath work. I mean, movement, movement that is safe for you. I mean, there was a point where I modified the Tai Chi where I was just sitting there and just able to just move my arms. That's all I could do, and I worked my way up from unable to walk to walking again. So all these things is part of like that comprehensive approach that would be customized for you working with a doctor like Dr. Groysman. So you're lucky you get the best of allopathic, right? Allopathic and functional medicine.
I am not your typical allopathic doctor. I think you
Right.
realize that already.
Yeah.
Um, and this kind of goes into this next question or statement. Um, I mean, I do think vaccine injuries are being taken more seriously. I mean, we just had a session in Congress about it, correct?
Uh,
About people testifying about vaccines and
yeah. And the South Carolina Senate had some
no,
talks.
that's a different one. That was local, but we
Yeah.
had one in
Oh,
Washington recently
okay.
with
I have.
Bernie Sanders.
Okay, gotcha. I remember. Um,
He's head of that committee.
gotcha.
So
I
I
thought
do
they
think it's
focused on
starting to be
long
taken.
COVID mostly.
They did, but they may have mentioned one or two things about the virus, the vaccine. I mean, my point is, I think it is being recognized now. Um, Doctors in general tend to move very slow. It's slow to accept new conditions, new treatments, things like that. In general, um, and I think part of it is from the medical liability. I mean, um, doctors don't want to get sued, and when you're dealing with something new, you just don't know.
And
Um,
MCAS,
I think the opposite.
you mentioned
I
MCAS
think
was
I
just
think people are
defined
more.
in 2018. I'm sorry. Go ahead.
I think people are more appreciative that you're hearing them out and not gaslighting them. So I mean, I kind of look at it from the other side. MCAS is roughly 20 years old. Frank is asking, is the SGB to reset the vagus nerve? No. The SGB is ganglion procedure, not block, I call it, is to reset the sympathetic nervous system. So that's the opposite on the other end of the seesaw. Um, I do try to free up the vagus nerve if I notice a lot of thickening, but it's not really meant to reset the vagus nerve. It indirectly would increase vagus nerve function because you're decreasing sympathetic nervous system function. So the parasympathetic kind of comes up, um, but it doesn't really reset the vagus nerve. Okay. This is a great question. I get asked a lot in the office too. Do I recommend vagus nerve stimulation for a certain period before getting an SGB? So I nerve stimulation anyway. Do you do the SGB or not? Because it has two purposes. One, if your sympathetic nervous system is always high, if you're 24/7 in fight or flight, to um, be under parasympathetic control for a period of time. That's number one. Number two, it lets your body heal and repair. So things like digestion and maintenance happen under parasympathetic control. And if you're not in parasympathetic at all, ever, even if it's there, the tone is diminished, you're not repairing your cells. You're not having cell turnover. You're not generating new cells from the stem cells that you have in your body. You're not able to heal. So you would notice things like cuts and stuff take way longer to heal than they did in the past. And that's because your body is focusing on fight or flight. There's no time to repair when your body feels like it's in mortal danger. There's no time to digest when your body is feeling like it's in mortal danger. There's no time to sleep when your body feels like you're in mortal danger. So it helps with all these things. It's not absolutely necessary to do vagus nerve stimulation before doing the SGB, but I have everybody after the SGB do it to help maintain it. To help remind your body, hey, this is the normal tone. This is where you need to be, not the fight or flight mode. Okay? So you can do it beforehand, but you don't have to. But I do recommend doing it after the block. Okay? Another question about the HTB. Does it help with the arrhythmia? So it wouldn't directly help with arrhythmia unless it was caused by the sympathetic overdrive. So the most common arrhythmias that we see in long COVID is a sinus arrhythmia, and it's just a tachycardia. Okay, it's a sinus tachycardia, and with that it should help. But if you have an SVT or you have a ventricular arrhythmia or something else that not directly associated with long COVID, it's probably not going to help all that much. If there's a defect in the heart, for instance, if you have a block, I'm talking about an AV block, where signals are not getting from your atrium to the ventricle, that's not going to help either, because that's a mechanical problem with the heart, whether it's from an infection or from heart attack or something like that. Okay. What's interesting is the stellate ganglion block is used for atypical angina, where it's they look at or persistent angina that's not responding to medications. That's chest pain from your heart being referred up to your shoulder or your face or your arm. That's what I'm talking about, the chest pain. Okay? It is sometimes used for that. What do I use for the block? Well, first I'm going to say that I don't do a typical stellate ganglion block, which is why I refer to it as a stellate ganglion procedure. And it's not what you use, it's where you put it. Okay? I can use any of the local anesthetics with or without steroid, and it wouldn't make a difference. I mean, the time that the block would be effective would make a difference, but as far as to the efficacy, I believe it has to do with where it's being put, not what is being used. But I use a combination of, and as I said, it's not what you use, it's where you put it. Location, location, location. It kind of goes back to that, okay? Sleep cycles. So one of the biggest complaints that people with long COVID have, I don't sleep. I can't fall asleep. I can't stay asleep. I sleep, but I feel
too much.
as tired. Right. Sleep too much, or I wake up after 8 or 10 hours and I still feel like crap. Okay, this is a very common finding in people with long COVID. It has to do with anomia, okay? And again, I go back to what I said earlier. You're in fight or flight mode. your body does not want to rest because it's in fear from mortal danger. Okay, it may not be appropriate, but as far as your body is concerned, you're gonna, you're gonna have to either fight or run, and you feel amped up, and you can't get into deep sleep. I did a video on this, also on my YouTube channel, for deep sleep, and I talk about this. But your body will not let you go into deep sleep because it fears that you're in mortal danger. And you need deep sleep in order for the parasympathetic to do its job, which is repair, digest, heal, and do all the maintenance functions that you don't have to think about it. They're just done for you. But what you don't realize is under long COVID, you're not repairing, or you're not repairing very well. You're not doing the turnover. You're aging faster than chronological age. And that happens because you're not turning over the cells that need to be turned over. Okay? And that's true for any organ in your body, including your skin. So you really need deep sleep in order to be able to feel rested. Okay? REM sleep is great for your brain to process the events of the day, the events of the week. But from the EEG standpoint, you're pretty much awake. If you look at an EEG of a REM sleeper, they look identical. The only difference is your body shuts off your motor function basically from neck down, so that you don't act out. But other than that, everything else does not. REM sleep is deep sleep, where the delta waves are the main source of the EEG from your brain. Okay.
Yeah, I remember there was
Let's see
only like
here.
maybe one time in my life I was
I think
awake for 3 days. I'm sorry. Am I um, delayed again still?
you're like 2 minutes delayed.
Wow. Okay, maybe I'll leave and come back in. Try
All
again.
right. Well, I think I addressed the sleep issue. Why? Well, because you're not going into deep sleep, and because your body is in mode.
I did have one question about how um,
To the
during issues with
ANS cause tremors. So tremors are often associated with anxiety. I'm not saying that anxiety causes tremors. Okay, them connected together, and I'm assuming we're talking about. Um, Hang on, I think Amira's back. I'm assuming we're talking about not intention tremors like in Parkinson's, where the tremors are only when you're moving or trying to move. You're just basically okay. There's a condition known as benign tremors that doesn't really have a cause, and a lot of people just place words, which helps with the anxiety plus the tremors. But I think in long COVID, I think it's different. I don't think it's coming from the ANS directly. I think it's associated with anxiety. I'm not willing to prescribe monoclonal anti. I'm assuming you mean kinase inhibitors. 100% sure. Am I willing to prescribe it? I mean, I prescribe them. Yeah. The issue is these monoclonal antibodies, they are very expensive and won't be covered by insurance for main inhibitor. The cheapest antibodies, I guess, would be IVIG, but outside of ones that are specific treatments, they're expensive though, out of pocket. Just just something to keep in mind. So I do test my patients for if I suspect conditions and treat it, Chris, similar to somebody with lupus, um, or rheumatoid arthritis or Sjogren's or one of the seronegative rheumatological conditions. Um, but yes, they do sometimes show up positive, not very, but they do show up positive occasionally during testing. Majority of patients. That doesn't mean 100%. I've had one or two outliers that have not improved with their insomnia after a stellate ganglion block, but the majority of people do. In general, some of them become to change, and that has to do with me. And your body basically starts accepting the new fight or flight as your new normal. So anything you can do to disrupt that will help basically original balance that exists. This is a very non-specific question. I mean, you have to tell me which hormone you're referring to. I guess hyperthyroidism, high thyroid hormone production. But typically, things like estrogen or progesterone shouldn't cause tremors, uh, even if there's an imbalance. Me, right?
How
Because
about,
Amira is frozen on my end.
okay, I'm gonna leave and come back.
This is a good question. I get asked this quite a few times. Is an internal vibration same as tremor and by anxiety? No, I don't believe so. I don't think this is caused by the same mechanism. I believe an internal vibration to be kind of like a neuropathy, kind of like a pins and needles sensation, except you feel it as a vibration. And it can happen in the limbs, it can happen in the chest or stomach area, but I don't think it's related to anxiety. And I don't think it's the same as a tremor. Roland is asking about severe case of POTS and if I would recommend increasing mobilization, even if it makes syncope incidence increase. I don't think um, going through syncope intentionally is a good idea. So the best way is to treat the POTS in the first place. And there's a lot of conservative ways to do it, and there's some medications to do it. But pacing is the best way to, I guess, avoid some of the consequences of it. But if you're passing out, if you're actually going through syncope, you're probably going to need some assistance um, to reduce the incidence of syncope rather than increase them. I think Amira is back. Your voice is off.
I apologize. I had to completely come out of the app, and sorry for missing any of the questions. Can you all hear me okay?
I can hear you.
Okay.
I'm not sure what MTC oil is, unless it's some kind of marijuana based thing. I'm not sure. Do you
No, it's
know?
usually like mid chain fatty acids,
No, there's
I
no
think.
fatty acids there at MTC. That's why I was asking
To
not to use
abbreviate.
abbreviations, because
These are
I sometimes don't
you
know what you mean.
yeah, usually it's derived, I think, from coconut when they talk
Okay,
about
middle chain fatty
mid-chain
acids.
length. Usually mid-chain length. I've seen it before written like that.
Sure. I mean,
But
coconut oil has been shown to be helpful with certain things. I mean, I wouldn't necessarily use that for sleep though. Middle chain triglycerides. Okay,
yeah.
there you go. Yeah, I have read something about that in helping with inflammation in general, but
And the
I don't
brain.
know about. I don't think it really is associated with sleep or fatigue. It's basically a fatty acid. I mean, there's really kind of several different fatty acids: short chain, middle chain, and long chain, and then there's triglycerides. Um, and they're often used in membrane synthesis. That is how cell forms. Okay, and of course they can be used for energy with a little bit of tweaking to be turned into pyruvate and then be thrown into the citric acid cycle or the Krebs cycle, whatever you like. So, but as far as insomnia, I don't really think it's necessarily useful. I don't think it is harmful either. Um, but
It's like not one thing fixes all of long COVID. You have to do a comprehensive from everything
yeah,
I've
I mean,
seen.
yeah, yeah. Each of my treatments is going to be unique and different, and um, can MCAS and dysautonomia go away if root cause is addressed? Yes,
Yeah.
yes. But they are the root causes, though. So I treat them directly. So the symptoms coming from dysautonomia and the symptoms coming from MCAS is what I focus on. Not the symptoms caused by them. I just use the symptoms to help with diagnosis. Okay, so MCAS and dysautonomia I feel are two of the causes, and the other two are mitochondrial dysfunction and gut dysbiosis. And by focusing on the ones that are most active in that particular person, I can get to the bottom of it and treat it. Um,
It ends up becoming a lifestyle, literally to keep, yourself together from what I've
yes.
noticed over the past 4 years. You let go of one thing, and next thing you know, you've got an MCAS flare or, a joint popping out or something, you know.
How do I fix my fatigue? I'm not sure that I have. Um, I mean, some days are still really rough. Um, but
He's very
I,
disciplined. I admire his discipline. He's like, "Have you seen this paper?" And I'm like, "Have you seen this paper? What do you think of this?" I mean, not many doctors are doing a full day of patients and then studying and then answering questions to help people on a Facebook group, and then do these. So I'm like, God, I have to, like I want to keep up with him. It's like
I believe me, on the weekends I collapse sometimes. I mean, I'm exhausted. Um,
I think in one
After I'm
year
done with my day, I'm exhausted.
he said I need 1 month to get caught up on some things and take time for myself and see my family. I think y'all are very lucky. I had not met anyone else during this pandemic. There are a lot of good people who've done a lot of good work and are my pandemic heroes. But Dr. Groysman picked up the phone one day and said, "How can I help?" And I was like, "Oh my gosh, that was like an answer from my heart praying to God." And the phone, like, "How can I help?" And ever since, no matter what, how hard it's been, we're trying to get the latest information, the latest research, and we go at it. Like sometimes I'm like, gut dysbiosis, biofilm, microbiome, supplements, and I have to prove things to him. And likewise, he teaches me, I didn't know anything about this vagus nerve. I'm learning whole systems from Dr. Groysman. He's been really generous in teaching us. So you guys not only are learning about long COVID, you're learning how to take care of your bodies. Nobody gets a manual when you're born, how to take care of this human body. This is really good information. So, anyway, sorry about that interruption.
No, it's okay. I have to go right at 5, as you know. That's my hard stop.
Okay, so 10 minutes. So,
But
go ahead.
yeah, do you think they're close to finding a cure? And if so, do you think it will look combination medications such as with HIV? Because there's so many different systems issues involved. I think I am close to finding a cure. I don't know about they or them. There's a lot of things being thrown out there, including complement and including interferon gamma. And of course, a few weeks ago was serotonin, low serotonin, and before that it was microclots. I mean, there's constantly things coming out, but I'm choosing what to listen to and what to ignore because I think a lot of that stuff is going to be basically the victim or the cause of the consequence rather than the cause. Um, and I think that the treatment is going to be different than the treatment for HIV/AIDS, which focuses on antiviral therapies, and that's because that is a retrovirus and it inserts itself into the DNA and it continues to produce active virions. This has not been demonstrated with COVID-19 or SARS-CoV-2. Now, we found viral components, but we have not found active live virus. Okay, that's very important.
But I
Okay,
will bring up the work of
I know
Dr.
there's socks like
I'm sorry. I thought you
I
were
know
done.
there's some
I was going to
doctors.
say,
Um,
go ahead. Sorry.
I know there's some doctors like Dr. Patterson that use medication, Moravrock, for instance, and some docs have tried using Paxlovid or antivirals to treat long COVID, and I'm sure you kind of know what the results are. If it was a replicating virus, an antiviral should knock it out fairly quickly, especially if you continue taking the antiviral. So
Yes.
that's why I'm not considering.
Yeah. Also, you have to look at the target of the virus. There's a more specific target with HIV where it is targeted. SARS-CoV-2 infects almost everywhere in the entire body and gut microbacterial cells. It interferes with your absorption and causes malnutrition states. It's like goes everywhere. So how do you solve something like that except going in steps in the right order, like Dr. Groysman says, and addressing and really good clinical observation to see where the person is at and avoiding COVID in the first place? I'm really surprised about how things are going with that. And I just pray people keep themselves safe and support their immune system, as best they can. I really wish there were more solutions out there for protecting people from this virus.
Well, let me get to the last couple of questions here
Sure.
before I get
Okay.
off. Is 5-HTP helpful? This is a precursor to both tryptophan and melatonin. Um, it can be helpful if you're having absorption issues with tryptophan or 5-HTP. It's probably worth testing for before supplementing, because if you produce too much serotonin, you can get into trouble with serotonin syndrome, which has its own set of problems associated with it. No, I don't think you're going to get serotonin syndrome from supplementing, but if you take another medication that inhibits one of the enzymes that breaks it down, that could potentially result in a large quantity of serotonin in your bloodstream. What percentage of success have I seen with insomnia and fatigue? It's relatively high. I would say greater than 90% for both of those. Like I said, for insomnia, it's probably 99%. I've only had two patients that I could recall out of many, many, many patients that have not had their insomnia improve. Um, this is a question about tremors. I've answered this question a few times actually. I said that it depends on the kind of tremors that we're talking about. Okay. If we're talking about just a general tremor when you're sitting there not doing anything, it's in your hands, it's in your legs. Um, that can be associated with anxiety. I'm not saying it's caused by anxiety, but oftentimes I found that those kind of tremors are associated. In other words, the patient has the tremor, but they also have anxiety to boot. I'm not saying that it is a cause of the tremors. It's just I find them together often. If we're talking about like an intention tremor, where there's no tremor unless you're moving, more like Parkinsonian, that's different. If we're talking about vibrations, which was also asked, I believe that mechanism is from neuropathies or neuropathic mechanism, not due to actual muscle movement. Okay.
How about during hypoglycemic events? Because Bobby
Well, you
is.
can get a seizure from that. I mean, that's something we've seen with severe hypoglycemia. That certainly can make anxiety worse and cause tremors that way as well. Being hypoglycemic, I said I know I'm going to be hypoglycemic, and I sometimes develop tremors from that.
I worry about, I started with this continuous glucose monitor just because of my son and what he's going through. And I had alarms going off while I'm zonked out asleep in the middle of the night, 40 sugar, and a friend of mine just passed away who had a 38 sugar. I mean, what is happening when our sugars plummet? Are we doing repairs in our body and we're okay? I mean, I don't understand when we're not doing massive activity movement wise, why our sugars would just. Is that part of the dysautonomia?
Dysautonomia typically would cause hyperglycemia, not hypo. I think it's a liver issue.
Okay. More questions. More data needed. Okay.
All right. Well, this will have to be the last one or two here. Actually, I don't see any other questions. They're just comments. I can
Thank
take
you.
one
Always.
more question if you guys have, but that's it, and I gotta run.
I just want to say thank
I
you
know we
again.
didn't get to the, I know we
Oh
didn't get to
yeah.
this back to this again, but is there any parting words you want to say
I wanted to mention
before 5?
really quickly if you could explain to us. Now I'm going to have to enlarge my screen somehow. Hold on. Let's see if I can do that. I'm just going to have to. I don't know if there's a way you can make that a little bit larger, but from my
I mean, I can make it
recollection.
larger, but I don't know if it's going to be better for you. It only
Oh,
makes it
okay.
larger for me.
For other folks, I did notice they listed several things contributing to the circumstances of the death: congestive cardiac failure, hypercalcemia, and the vitamin D toxicity, ischemic heart disease. And if you could scroll down just a tiny bit, um, there we go. They did mention this the chronic kidney failure. Okay, so with the chronic kidney failure, sometimes there's something called secondary hyperparathyroidism, and related to that is the toxicity or the issues with calcium buildup and uh, calcification in areas of the body. You would explain this way better than me, but I know that somebody missed monitoring this person if he got all the way up to 380. I mean, that's a long time to be on
Yeah, I mean
med.
that's an astronomically high dose in his blood, obviously, of calcium. Calcium
Or
is
vitamin
involved
D.
in
It
nerve
said
conduction.
vitamin D 380.
Right, but he also had hypercalcemia, which
Okay.
means high calcium concentrations in his blood.
Okay.
And while we do need calcium well controlled, that's what parathyroid hormone does for the most part, is it regulates blood calcium levels. Um, However, when calcium is high in the blood, it can lead to things like neuropathies, things like muscle spasms and cramps. Okay,
And the heart's a
it can
muscle,
cause
right?
seizures. It can affect the heart as well. It can cause heart failure. It can cause seizures and cognitive impairment. So, typically, though, that has to do with a quick rise in. Um, I'm sorry, I'm telling you things about low calcium um, in the blood. There's other symptoms that occur with high. Uh, yeah, there's just not enough time though to really
Yeah.
discuss this. I'm sorry.
We can do
Uh,
it next time. We can do it next time.
but
And
muscle
just
twitches or weakness is part of hypercalcemia. Okay, that's all
thank
I
you.
can add.
Okay. I just my mother had
Yes,
chronic kidney disease
kidney
and had to
function.
watch her intake of calcium in her
Well,
diet.
the big
And
thing with kidney disease is that in chronic kidney disease, activating vitamin D. Okay, it's just
yeah.
I didn't get into it, but you have two steps in, and the second step occurs at the kidneys. It's also where
Mhm.
calcium and phosphates are excreted. So um, you could potentially have increased vitamin D circulating, even if it's not activated. It still has function, or if it's partially activated through the liver.
Mhm.
Um, and it can cause problems that way in chronic kidney disease. All
Gotcha.
right, I gotta run. Let me turn this off, and I will see you in 2 weeks at
10
a.m. Also on a Sunday, 10 a.m. on Central, 11 a.m. on Eastern. Okay, and I'll see you guys in 2 weeks.
Yeah.
All right, thanks. Bye.
Thank you. Bye. Get your questions ready and be sure to go to covidinstitute.org for more information and long COVID association or .com or longcovidassoc.org. And we're here to help you get answers. Be sure to follow us on all your social media.